Yes, sir, you can start now.
Okay, good evening everyone. Myself Dr. Neeraj from HiGlance Laboratory. It is my great pleasure to welcome you to the webinar. It is with great honor that I am going to introduce today's speaker to you, Dr. Abhyuday Verma and Dr. Prashant Advani. Dr. Verma is the director at Super Specialty Endocrinology and Women Care Center, and he is also associated with Index Medical College and Research Institute in Indore. Today, he will discuss on topic pioglitazone in Indian type 2 diabetic mellitus. Dr. Advani is the director at Advani Heart and Metabolic Center. He is also associated with several corporate hospitals in Raipur. Today, he will discuss on topic heart failure management in middle of 2021 is state of the art. We would like to thank the great cadre of doctors who have faith in our quality product. Now, I would like to hand over this session to Dr. Verma. Dr. Verma, please.
Thank you, Dr. Neeraj, for the kind introduction. And friends, we are now in a state where we have lot of drugs, especially oral hypoglycemic agents in our armamentarium, which can help us to control blood sugar levels, especially in our Indian type 2 diabetic patients. But I would like to re-emphasize today the role of pioglitazone, which was or had a setback in last decade because of few cases which were seen with rosiglitazone, that was increase in the heart failure incidence. And then we had a couple of years back a controversial study or some data regarding increasing bladder cancer with pioglitazone. So this made a lot of us, including very hardcore diehard fans of pioglitazone, either stop this drug or underuse this drug. Lot of combinations were available, triple drug combinations with pioglitazone, metformin, glimepiride, which were quite easily available, improving the compliance in type 2 diabetic patients, and along with that giving us a very good HbA1c control at a very affordable rate. So this was the beauty of pioglitazone, and still I would say with so many drugs in our armamentarium, including the latest DPP4 inhibitor or SGLT2 inhibitors, we should still be sticking to the use of pioglitazone, especially when we talk about Indian type 2 diabetic patients. So in my talk, I would be talking briefly about the exact role that why pioglitazone is important in our Indian context, and how especially the Indian population could be benefited with the use of pioglitazone. And we have all these. We can see here that 82% of our Indian type 2 diabetic patients, they suffer from insulin resistance. This is the main problem with Indians when we compare ourselves with the Caucasian population. And then we have this also, the Indian consensus document, which has specifically talked about pioglitazone and its role in the Asian phenotype, where we have maximum insulin resistance and higher waist circumference compared to any other population globally. So this is the root cause? The insulin resistance is the root cause for type 2 diabetic patients, especially in our Asian or Indian type 2 diabetic patients, along with other metabolic problems also. Few words about insulin resistance. We all know, friends, that this is basically the inability of the tissues to respond to normal levels of insulin. Normally, what happens to the circulated insulin in the body? It increases the muscle and adipocyte glucose uptake via GLUT4 translocation. It increases the glycogenesis, lipogenesis, and other anabolic processes. It decreases the glycogenolysis, lipolysis, proteolysis, and gluconeogenesis. So you can see now that if there is an insulin resistance, then we would be having problems with all these metabolisms of glycogenesis, lipogenesis, and even anabolic processes also. And all these insulin functions are mediated through tetrameric receptors like tyrosine phosphorylation, IRS1, and various protein kinases and phosphatases. So we have either problem at the cellular level or at the receptor levels, especially in our Asian or Indian population, which leads to insulin resistance, especially in our subset of population, especially the Indian population. So what happens with insulin resistance? Why this is more important when we talk about type 2 diabetes mellitus management? Because with insulin resistance, body tries to make more insulin. So there is a state of hyperinsulinemia, and which obviously puts our beta cells at more risk of getting exhausted, which are already overburdened because of the pathophysiology of type 2 diabetes mellitus. Then we have insulin resistance. This leads to higher sugar levels in the blood, and this sugar level is stored in body as fat. So when the sugar levels are not utilized by cells, but it is stored as fat in body, the person becomes more fat, but still these cells are starved of glucose. So the person feels tired and hungry, and they eat more food, and this again leads to hyperinsulinemia. And this is a vicious cycle, that how in a state of abundance of sugar in a hyperglycemic patient, these cells are starved of sugar levels, and ultimately the patient eats more, becomes more fat, and there is hyperinsulinemia because of insulin resistance. This leads to various metabolic abnormality. That's why it is important to talk about insulin resistance. Various studies. This is a data from meta-analysis of various studies done from early 90s to late 2000. And here they have shown that people who have insulin resistance are not only diabetic patients, but here we can see from age above 40 years, people with coronary heart disease, people with stroke, people with hypertension, they all have 50% of them, they have insulin resistance. And not to forget, obviously 80 to 90% of our Indian diabetic population who typically have this phenotype, of dyslipidemia, where we have low HDL cholesterol and high triglyceride levels. So this data shows that 80 to 90% of our type 2 diabetic patients, they have insulin resistance. And not to forget other hypertensive, stroke and heart disease patients who also have insulin resistance. And if we don't control insulin resistance in these other subgroup of patients, they may land up in various metabolic abnormalities. And this is again re-emphasizing same thing, that why insulin resistance is important, because it is associated not only with type 2 diabetes, it is associated, or it is the mother of various metabolic abnormalities like hypertension, impaired glucose tolerance, central adiposity especially, which is more harmful compared to overall adiposity. It is closely related to polycystic ovary disease, which is quite a common problem in female with menstrual abnormalities. It increases the uric acid levels also, acanthosis nigricans, decreased fibrinolytic activity, dyslipidemia, atherosclerosis. So we can see here that most of the problems related to the insulin resistance are the cardiac, renal problems along with various other metabolic abnormalities. Why Indians diabetic are special when we compare them with other population? We all know that we have a rapidly escalating epidemic of diabetes and obesity, which is due to insulin resistance syndrome. And a lot of studies, again I won't go in detail, we have this insulin resistance epidemic in India, where they have shown that this starts from fetus and later exaggerated by poor lifestyle, which was published on 1st January 2001 as insulin resistance syndrome and obesity in Asian Indians, which showed that Asian Indians have a higher prevalence of insulin resistance that may underline greater tendency for us compared to other population to develop diabetes mellitus and early atherosclerosis. That's why we get early diabetes in Indians. That's why we get early heart disease, atherosclerotic disease in Indians. And the main problem is that Indians, they have higher body fat, especially the central adiposity, compared to other races or Caucasian population, which is basically programmed in utero. So it is basically the fetus origin, and obviously later on our poor lifestyle, which leads to insulin resistance. So this is our India. India is unique, obviously, in a lot of things. People can't compare themselves with Indians. We have a lot of things which are unique. But along with that, we have diabetes also. Indian diabetics are unique. So we have to think of management of diabetes also separate, which is unique for Indians, not restricted to the association or guidelines which are specially made by seeing Caucasian or other race population. And this is, again I won't go in much detail, but this is a typical Indian diabetic patients, where we have white adipose tissue, which is a lipid storage organ which increases with adiposity. It is composed of adipocytes and stromovascular fractions, where they act as a endocrine organ also. It secretes leptin, adiponectin, TNF alpha, interleukin 1 beta, 1 RA, interleukin 6, interleukin 10, and they all participate in insulin stimulated glucose uptake, release of free fatty acids. Liver also, here we can see hepatic insulin resistance leads to increased hepatic gluconeogenesis and lipogenesis along with accumulation of free fatty acids. In skeletal muscles, these are the main target for glucose uptake in the body, and again here also glycogenesis is followed by glucose uptake, and this defective glycogen synthesis is linked with insulin resistance. So this is a typical prototype or phenotype of an Indian diabetic. You can see we have problem in our skeletal muscle, we have problem in our adipose tissue and liver, which makes us more insulin resistant and leads to all these problems, which ultimately lands up in a lot of metabolic disturbances. So the South Asian or Asian Indian phenotype, in spite of our lower BMI compared to a Caucasian population, we have more abdominal fat, we have more insulin resistance, we have higher levels of C-reactive protein, we have lower levels of good adiponectin, and we have characteristic dyslipidemia, which I have already told, low HDL, high triglycerides, and high levels of small dense LDL, which increases the susceptibility or risk of thin fat Indians to develop more type 2 diabetes mellitus and coronary artery disease. And as I've already told, all this along with genetic factors leads to increased inflammation, thrombosis, and accelerated atherosclerosis. And now I will talk about pioglitazone, that how pioglitazone, especially I have chosen to say, helps especially our Indian population, and it is one of my very favorite drugs, especially when we talk about management of type 2 diabetes in the Indian population. Studies are there where it is shown that pioglitazone helps in beta cell regeneration. N number of studies are there. Pioglitazone can be used with any of the combination of the available OHAs or even with insulin also. It enhances regeneration of endogenous islet beta cell. We have therapies for reducing insulin resistance. So insulin resistance, very common in Indians. We should follow non-pharmacological and pharmacological methods to improve the insulin resistance, which is present in almost every type 2 diabetic patient or a obese or a hypertensive or a dyslipidemic patient, Indian patient. So we should advise them exercise, weight control, diet, and smoking cessation. Amongst the drugs to reduce insulin resistance, we have widely available cheap drugs like metformin and thiazolidinediones. Especially, I would talk about pioglitazone because we are not using rosiglitazone now. Metformin, we all know, is the first line agent for type 2 diabetes mellitus. We know the efficacy is good, lesser chances of hypoglycemia, neutral, or it may help in weight reduction also, and the cost is quite cheap also. So if until unless contraindicated, it should be preferred initial pharmacological agent for type 2 diabetes mellitus. Then we have sulfonylureas. We all know that metformin and sulfonylurea combination is one of the preferred combination in almost 80 to 90% of our type 2 diabetic patient because of the easy availability and lesser cost. And we have seen a lot of data also that it is quite effective and it can control patients' HbA1c above 8 and bring them to target below 7% also, and it maintains the glycemic durability also for up to 7 to 8 years. Then we talk about pioglitazone. So maybe after initial metformin or after a combination of sulfonylurea and metformin, if the blood sugar levels are not controlled, then we can either choose pioglitazone as a second line or a third line option. And this is the comparison of various parameters with the available drugs favoring the use of pioglitazone, where we can see when we have, especially our Indian population, I would say, when we have in our Indian population the insulin resistance, higher chances of insulin resistance, central adiposity, we have pioglitazone, which scores better than any other class of drugs, even with SUs, AGI, or SGLT2 inhibitor also. Beta cell preservation is present with pioglitazone. CV event risk reduction, I won't go in much detail, but there are studies where they've shown reduction in CV events, CV risk factors. Then we have other lot of pleiotropic benefits also, which is like the talk of the town today, that we are now not glucocentric. We go for extra pleiotropic benefits with the drugs we use to control blood sugar levels, and obviously good HbA1c reduction. So most of these criterias, which are really important for our Indian population, the beta cell preservation, insulin resistance, CV protection, pleiotropic benefits, and good sugar control, they are all seen with the pioglitazone compared to any other agent available till now. And these are some of the preliminary data which support the reduction in myocardial infarction with PPAR gamma activation with the use of pioglitazone. And this is comparison between sulfonylurea, metformin, and thiazolidinediones. PPAR gamma activation is associated with lower mortality. Here we can see Dr. Advani definitely would be talking about heart failure, but here contrast to what studies were claiming about rosiglitazone. This is one of the very oldest study, almost 15 years back, but here you can see with more than 16,000 patients, diabetes with HF, thiazolidinediones, especially pioglitazone, showed 13% relative risk reduction in patients with diabetes and heart failure. All-cause mortality, HF, were comparable with metformin. Proactive study, again a very good study. I won't go in again detail. Primary outcomes of all-cause mortality, MI, ACAS, peripheral coronary revascularization, amputation, stroke, they were all 10% relative risk reduction seen with pioglitazone compared to placebo. Reduction in secondary outcomes also. Silent MI, stroke, again 16% relative risk reduction with pioglitazone compared to metformin. Landmark IRIS study, again 60 years, 40 years patient, around 4,000 patients with qualifying ischemic stroke or TIA, no diabetes, but they had insulin resistance, pioglitazone. Here, over 5 years, showed benefits, where here we can see there was a marked reduction in the primary outcomes with the use of pioglitazone in high risk individuals. They were not diabetic, they were just having insulin resistance, but you can see here primary outcome, stroke reduction and MI reduction with the use of pioglitazone. Bladder cancer, again I will not go in much detail, but there were some concerns regarding bladder cancer with data, but now I think most of we all know that it was just a hoax, and there are a lot of studies which are saying that this is just a blunder about pioglitazone and bladder cancer. If we talk about Indian data also, compared to India, Caucasian population, Indians, they have less chances of bladder cancer also. Caucasian population, somehow they have a higher risk of bladder cancer. So maybe in those studies, they might have got more cases. But in India, we already have less bladder cancer. So we are at lesser risk of developing bladder cancer anyhow also. And obviously, with pioglitazone, there were not many studies also showing increasing bladder cancer. And this is one of the studies where Diabetes Care 2011, it was published, the 10 most common insights, and they said that with pioglitazone, there are no clear evidence of an association with increase in incidence of cancers. Few studies they show, yes, macular edema is a problem, but yes, if we use in correct subset of patients, then definitely that diabetic macular edema problem also, which is rarely seen with use of pioglitazone, can be very well taken care of. Weight gain, again, a lot of people they say weight gain is, but when we see studies like proactive also, they say that mean body weight increase over 5 years was just 3.6 kgs, and it was associated with improved survival of the patient. So maybe there was a slight increase with in weight with pioglitazone, but then they said that there was an improved survival also. So when they compared the risk and benefit of this weight gain with pioglitazone, they showed that there is more benefit compared to a slight increase in weight over 4 to 5 years duration with the use of pioglitazone. Heart failure, again, as I've already showed, proactive studies, they have just shown a slight more chances of heart failure with the use of pioglitazone, or I would say these are all comparable, just 5.7% and 4.1% with the use of pioglitazone compared to placebo. But interestingly, there were fewer cases of serious CHF or death or MI or stroke seen in these patients with the use of pioglitazone to the tune of 34.9% versus 47% with placebo. So in the end, I will conclude my talk here just with a note that pioglitazone is forever, especially for our Indian population. Easily available, affordability is there, and it takes care of our Indian pathophysiology, takes care of insulin resistance, good sugar control, and durability in controlling the blood sugar levels. 2 decades of patient data is available. A lot of us have used and are still using, and we all know that if we use it judiciously, it is a really wonderful magic pill for most of our Indian type 2 diabetic patients. It delays insulinization. I have personally seen a lot of our type 2 diabetic patients who are insulin resistant. If we start pioglitazone, even if a small dose of 15 mg once daily, can delay insulinization for months or years together, because main problem in us is not the insulin secretion, it is basically the insulin resistance which should be taken care of. And Definitely, there are side effects, but very minimal side effects or adverse event profile. Only thing, we have to use it judiciously, especially in few patients who have a higher degree of heart failure or macular edema, and in postmenopausal osteoporotic females. Thank you.
Thank you, Dr. Verma. We will take the questions after the completion of the Dr. Advani talk. So, Dr. Advani, please.
A beautiful, exhaustive presentation, and I learned from it. And very plausible that we Indians are different and we have more of a resistance, and that's why we have the kind of pathophysiology that, and we use incorrect drugs, not understanding pathophysiology. We develop all these atherosclerotic complications and land up in heart failures. And then I have to do a talk after Dr. Verma's talk explaining all this. So I am starting sharing, and please help me technically. This is, yeah, is it seen? It's being seen here. Is it visible?
Yes, yes.
From beginning. How to slideshow from beginning. What do I do? It's changing?
Yeah, yes. Yeah.
So good evening, everybody, and thanks, Dr. Verma, for setting the ball right, because this is all these consequences of metabolic syndrome, cardiac diseases, heart failures, all start from metabolic dysmetabolic syndrome, and you have to understand it well. And you enumerated that calorie excess the way we Indian do, and then we accumulate so much of oodles of fat around vital organs and central abdomen, liver studied, perinephric fat, and all floods our system with so much of obnoxious inflammatory markers and oxidative reactive agents, and they wreak havoc to endothelium and land us up in all those chronic complications, coronary artery disease, heart failure, MI, strokes, and also cardiorenal continuum is part of it. So here we have to be very smart in managing all those things, and we have to first understand pathophysiology. And I'm glad that Dr. Abhyuday actually enumerated more of on pathophysiology and a typical genotype that we have in India and the phenotype that we have in India. I'm going to focus on heart failure, and why heart failure is very important, because diabetes is now considered to be a heart failure. Included, we always been learning in medical schools that it's a previous MI equivalent, but now another thing that is added is now heart failure is also a kind of a same pathophysiological feature that is shared with diabetes. So if you manage heart failure well, or if you manage diabetes well, you prevent heart failure, or if you manage heart failure well, you prevent new onset of diabetes. This is where is a new paradigm. But then I'm going to not only stick to diabetes, but entire gamut of heart failure, and where do we stand, and whatever new has happened. After this half an hour's good exposition by Dr. Abhyuday, I'll take another 20 minutes to wrap it up with all the pillars of heart. I'm talking of chronic heart failure with reduced ejection fraction here. And I'll say the very salient features, because all these trials are very exhaustive. Each trial can take entire 1 hour. So we have to just touch it so that we remember, and we practice it. Again, everything is very individualized in India. As he said that pioglitazone, if you say something, a very run-of-the-mill diabetes, or pioglitazone mani likhta bladder cancer, this doesn't happen that way. So you have to be very careful. You have to select, even in a very stable CKD patient or a heart failure patient, you can still write it in very minuscule dose to offer CV protection. Similarly here, heart failure is a very serious disorder emanating from, its very incidence is growing in India. 20% of people, 1 in 5 people, aged 40 years older, have run the risk. But then in India, it's percolating down. Even below 40, I see so many patients, and they just struck up. They just with their previous coronary event, and they have some structural damage, and come to me in their 30s and heart failure. And it's a very rapidly growing entity, and we have to understand it well. And each single hospitalization or episode sucks the reserves of your heart and puts you on a lesser pedestal and leaves you with a lesser reserve. And even further episodes and recurrent episodes, one episode increases the propensity for having recurrent episodes. The risk factors are the same as Dr. Abhyuday was saying: diabetes, hypertension, dyslipidemia, obesity, genetics, tobacco consumption, physical inactivity, and advancing age, not 60 plus. I said this is wrong. It's above 35 in India, and all is from Omenak's polysyndromic illness of this metabolism that he was enumerating. We have three types. We know that I'm talking of ejection fraction below 40%. This is where I'm going to delve. And there's so much of talk of HFrEF 40 to 50%, which was considered to be benign in early years, but it's not as benign as we know. And heart failure with preserved ejection fraction, which is another 30 to 40% of people. So apparently normal looking heart and echocardiogram. And then you sign the symptom of heart failure. Heart failure always a clinical diagnosis. And this is how the phenotype looks like. HFrEF on the middle side, you have a dilated remodel, a lost shape heart, and on the heart failure, preserved ejection fraction on the right, extreme right side. These are CMR pictures. It's a thickened heart with a smaller cavity side with accentuated contractility. An astute physician is going to recognize, irrespective, because diabetes transcends subspecialty. We have to be an astute physician in order to pick it up and offer the benefits. How does heart failure sets in? So any insult to cardiac myocyte and or extracellular matrix leads to alteration in size, shape, and function, and kickstart neurohormonal activation, which is SNS and RAS, and which causes widespread vasoconstriction, fibrosis, apoptosis, hypertrophy, cellular molecular adaptation, maladaptive adaptation, and myotoxicity, which leads to maladaptive remodeling and progressive worsening, and also hemodynamic alteration, salt and water retention. All that maladaptive remodeling leads to prognostic thing like arrhythmias, pump failures, and symptoms come for. So this is where all starts from, a structural damage to the heart in form of, say, MI or angina or asymptomatic ischemia. And you kickstart SNS, you kickstart RAS as soon as some subtle, even iota of damage that happens. And you raise your blood pressure, you raise your sympathetic tone, you raise your aldosterone 2, angiotensin 2 aldosterone level, which leads to hypertrophy, apoptosis, fibrosis, discrete fibrosis, extended fibrosis, architectural disarray, cellular and subcellular alteration, signaling alteration, so many cellular intracellular alteration, electrical remodeling, mechanical remodeling. The heart loses its shape, tries to compensate for it, but then ultimately loses its shape. And again, there's a vicious circle, perpetuating circle, mediated by chronic perpetual activation of SNS and RAS. Inhibiting SNS and RAS gives you mortality and morbidity benefit. Also, you kickstart from your left atrium, which is also an endocrine organ. As soon as you have an insult to heart, you have to understand that pathophysiological thing here. Natriuretic peptides and vasoactive peptides, which are physiologically totally antagonizing what these vasopressors are doing. So they decrease blood pressure, they decrease sympathetic tone, they improve natriuresis, they make you lose all unnecessary, unwanted salt and water. And vasopressin level goes down, aldosterone level goes down, aldosterone kind of a myotoxic substance, fibrosis, hypertrophy, and progressive dilatation and all architectural disarray goes down. So if you potentiate, hitherto we didn't have anything to potentiate endogenous, friendly natriuretic peptide system. Now we know that we are using neprilysin inhibition, we can potentiate them too. So this is where now we are heading in an era that we understood the pathophysiology of heart failure well. We have agents, and how we discovered those agents. I'll go to the chronology fast. Right, so you have stages of heart, stage A, B, C, D. What I'm alluding to is the stage C heart failure. I'm going to zero in here, where you have manifest heart failure. Stage A, we all are literally for stage A. We have all risk factors for heart failure. We have many of us has syndrome, dyslipidemia, family history, sedentary lifestyle, smoker, hypertension, diabetes, or we are Indian. That itself per se, or one or two major risk factors makes us as stage A. Stage B, you have a structural damage to the heart, but no heart failure set in. And we have ample opportunity to be dodging all those things, but then we have to be astute and very circumspect, vigilant enough. So previous MI, LV systolic dysfunction like congenital cardiomyopathies, LVEH, or asymptomatic valvular disease, where you have to be very very circumspect in order to dodge the development. Stage C is manifest, stage D and stage. We all know. Everything starts from non-pharmacological management, but nobody does it. Also in diabetes, also in heart failure. Low salt intake, weight reduction, exercise, daily weight checking, all this is a big topic in itself. All those trials for beta blockers, ever since I was in medical school, 91, I was following all salt trial for ACE inhibitors, then ARB charm alternative, and then the sheer emphasis for aldosterone antagonist. Then Paradigm HF that came and changed the landmark 20. Of course, Shift trial in 29 for evaporating for heart rate reduction. These are the trial names. I'm just for historical importance. Consensus and SALT for enalapril. And then we knew that inhibiting RAS inhibition actually gives you mortality benefit. All those trials then used to have endpoint of all-cause mortality. Now for heart failure trial, cardiovascular death and heart failure hospitalization are the endpoints. All were positive trials, and that's how we discovered that actually antagonizing the nature's compensatory responses to heart's damage, neurohormonal activation. If you antagonize that, you give survival benefit. Also for beta blockers, CBIS, HF, Copernicus, Capricorn, all these trials also antagonizing the renin-angiotensin and aldosterone excess. If excessive aldosterone causes fibrosis, prothrombotic effect, oxidative stress, vascular inflammation, and if you do these trials, RALS for with severe heart failure in spironolactone, FSS and emphasis for mild heart failure, and FSS for post-MI severe heart failure, eplerenone. These were all wonderful, phenomenal landmark trial with very, very significant p-values and number needed to drill under 25. And they showed us that in chronic HFrEF patient, if you use these neurohormonal antagonists as a standard of care, you improve the prognosis. So we had just triple therapy of heart failure specific beta blocker, RAS inhibitors, either ACE or ARB, or beta, and then mineralocortical receptor antagonist, either spironolactone or eplerenone. Eplerenone is more specific for the aldosterone receptor, and you have benefit. But then, in spite of that, like all these trials and all these drugs phased in, up till 2013, 14, 15, you had a residual risk remaining, a huge residual risk remaining. And then there have been recent advances to tackle that thing. And the ivabradine came as a heart rate, then angiotensin receptor neprilysin inhibitor, ERNI, or we call it sacubitril valsartan, which has changed the ball game of heart failure management. I'll come to it. Intravenous iron in India, because Indians are different. DAPA, then SGLT2 inhibitors, even for non-diabetic, DAPA-HF, AMPRA reduce, and verisuiguet, the nitric oxide provider. I'll come back to it. So this is where I'm also to address the residual risk and even further enhance. There was a neurohormonal era from 1991 to 2002 or 3, all neurohormonal era for heart failure. Then you have device era, CRTDs and SS devices, and then synchronization therapies. But there was a big hiatus for any agent is going to come to antagonize the neuro. Then we had paradigm HF trial sacubitril coming after 13 years of a big hiatus. And then you have sequentially, we are discovering that HFrEF, armamentarium, and the pillars are growing. This is something, beta blocker, MRI we always had. Then now neprilysin inhibition, SGLT2 inhibitors are diabetic drugs coming for heart failure patients rescue, verisuiguet, and ivabradine. Ivabradine, it's a funny channel inhibitor. And then it works in, and we know that heart rate is always a risk factor rather than a risk marker. If you have an established structural heart disease, which is kind of a stage B heart failure, even with manifest symptoms, if the SHIFT trial has shown that if somebody is on a guideline-directed beta blocker on maximum tolerated dose, yet the heart rate is above 70, and sinus rhythm, you have to administer ivabradine. This we know that. Then there is some mortality benefit there, and we are using for that indication. Then we know that potentiating natriuretic peptide system, chronic HFrEF as perpetual activation of SNS and RS. We always use beta blockers and RAS inhibitors, and now we never could potentiate. Likewise, in diabetes, we by inhibiting DPP4 inhibitors, you are potentiating incretin. Incretins are endogenous insulin facilitators and good extra the glycemic benefits, like good pleiotropic effect of incretins too, apart from anti-hyperglycemic age. Similarly here, natriuretic peptide system are physiologically totally antagonizing the effects of the ill effects, the overzealous and overboard effects of norepinephrine and angiotensin 2 and aldosterone. So they are anti-growth promoting, they are growth inhibiting, they are vasodilatory, anti-fibrotic, anti-apoptotic. So to preserve the cardiac parenchymal architecture. So the paradigm HF, we all know umpteen number of seminars. I must have done 20 with Novartis, how paradigm HF changed the paradigm. So trial inclusion, typical ischemic cardiomyopathy patient. Many of them had heart failure and when ejection fraction around below 30% and class 2 symptoms. So and they were on then guideline-directed therapy of beta blockers or mineralocorticoid receptor, and then compared against enalapril, and a very active comparator. And there was additional 20% reduction of cardiovascular death and a primary composite cardiovascular death and heart failure hospitalization. And we always think that somebody who's taking enalapril or somebody is taking a carvedilol and is stable in heart failure. No, nothing is stable in heart failure. You are talking to this guy and in your clinic and you think that the patient is for last 2 years stable. He can go for a walk and he walks 1.5 kilometers. A patient with ejection fraction of 34% and a prior PCI and a diabetic and is going around for 2 months and you don't have to change the dose. And you find that after 3 weeks of your last consultation with the same dose, this guy is suddenly dead. So something is happening. Something is smoldering inside. So what you see in clinic is just the tip of the iceberg. What's happening inside is this underlying structural and molecular abnormalities which are still smoldering. The underlying structural and molecular abnormality drive disease progression, which remains silent, which is asymptomatic, and you have to act smarter and you have to faster in order to reverse or prevent the progression of intrinsic cardiac structural and functional abnormalities, improve skeletal muscle function, afford necessary protection of kidneys too. If you have heart failure, you have to protect kidney too. There's a crosstalk every time going on, and even in a normal-looking heart failure patient. So there was many more studies. हमको पता चला stable chronic HFrEF patient, the secondary valsartan works. What about somebody who is having hospitalization, and then why not act smart right away in a dodging way? So there were transition trial, there was pioneer HF trial. We know that as the time, because patient is more compliant when he's in hospital and it's about to get discharged, and then you can tailor the therapy even in de novo heart failure. De novo means a new onset heart failure or treatment naive with RAS inhibition, you can start. And evaluate HF was a trial if it works on the central hemodynamics. Now that we know that many antihypertensive drugs have no effect on central hemodynamics. Like in life trial, we knew that losartan and atenolol didn't function because it actually doesn't affect your central hemodynamics. So central aortic stiffness is a key determinant of ventricular. So after having a phenomenal success in paradigm HF trial, the trialist went ahead to know that whether it affects the central hemodynamics too, but it was neutral as compared to comparator. And prove HF to mechanistic analysis. Such a phenomenal effect and such a life-prolonging effect of HFrEF patient. How does it happen? If it does in pioneer and transition, we knew that it does decrease the cardiac biomarkers, anti-pro BNPs, just within 2 months, and lets us up-titrate Ernie's dose to maximum, and it gives a mortality advantage, keeps patient out of hospital. How does it happen? So they found there's a reverse remodeling. The cartoon that I was showing in the beginning, that any structural damage to cardiac myocyte or matrix leads to progressive remodeling. The nature has given us a kind of compensatory thing which actually goes counterproductive over a long run, and by inhibiting them, actually you help the heart to go back to its previous pre-event structure, size, and shape, and function and pressures. So you decrease end systolic volume, you decrease end diastolic volume with chronic therapy with sacubitril valsartan, and you improve mitral inflow parameters. LVEDP goes down, filling pressures go down, and you eased out your congestion, your symptoms go away, and then you recover ejection fraction by 12 to 15%. I've seen in hundreds of such patients if you're very judiciously prescribing to a deserving patient. Even if, say, again I'm going in continuation, if he is a diabetic or insulin resistant, pioglitazone, another, as he just recapitulated with the talk, is a very cardio-friendly substance here. If you can control is volume overload, and you can just see that the patient is loading, and the patient is always in touch with you 1.5 months, 2 months, 3 months if you call him back. Sacubitril valsartan keeps Indian HFrEF patients alive. And Indian heart, why I'm using Indians? Because Indians have so much of widespread atherosclerosis. Even your major looking proximal RCA or LAD, or maybe normal in a 32-year-old metabolic patient, may be having so much of microvascular dysfunction through his AGEs and your polyols and so much of metabolic abnormality, mitochondrial dysfunction, maybe having so much of cardiac myocyte dysfunction, so much of microarchitectural disarray which is going on, and may even without coronary artery disease will end up straight away in a heart failure situation. So you have to be proactive here. So guidelines have taken the cognizance ever since the paradigm HF trial, and there's an addendum that ESC guidelines 220 update. So we are in 2021, update to the 2017 ESC guidelines for optimization of heart failure treatment, where they Germany has got the pace as a right to start with after pioneering in a very high risk heart failure patient. In India, we have very much a very rampant HFrEF iron deficiency, and there's so many, but then there never been a mortality improvement. There are trials going on, but if you have your ferritin levels in micrograms or 100 to 20 micron, your transferrin saturation below, so you have to give ferric carboxymolgus IV, and which we know that mentioned these trials. So there's a class 2B for Indian patient, a recommendation for VSC, but ACC doesn't recognize this thing. But just for updation, I've included this thing. So how would you recognize iron deficient? I have iron deficient even with normal looking hemoglobin. You have to go for serum ferritin. Once in a lifetime, for a urban or semi-urban or rural patient with high HFrEF, we have to go for iron studies to form out. If they are, you cannot go by hemoglobin. So at 13 hemoglobin, maybe having iron deficiency. And we know that by oral replenishment, it doesn't fulfill. You have to give parenteral. Now diabetes, again, coming back to, because diabetes is a big risk factor for heart failure. So you have, right at the time of diagnosis, stage is all set for both ASCVD as well as heart failure. And it's unrecognized complication. We raise our awareness about it. And if I admit a heart failure patient and without prior diabetes, known prior diabetes, 50% have stress hyperglycemia. And after their discharge, 50% end up in diabetes. After COVID infection, around 30-40% in Indian with background risk factors landed up into type 2 diabetes. So the bombardment of inflammation of the nervous system unmasks their vulnerability to land up into type 2 diabetes. And diabetes and heart failure is grimmer and bleaker than a malignant disease. And how diabetes affects? Through ASCVD, through coronary artery afflictions, I told you, by causing insulin resistance, as you were saying, 80 to 90% of type 2 diabetes are insulin resistance. With the relative hyperinsulinemia, you have insulin resistance. Skeletal muscles are saying, oh, I'm not able to handle this amount of insulin, so it's not going to enter in the blood for, as you were explaining, and it's very wonderfully explained, leading to hypertension, pro-thrombotic state, pro-inflammatory, the pro-growth promoting state, and then that actually affects the heart itself, and then the metabolic and structural abnormalities coming out of this. And there's a kind of a thing called diabetic cardiomyopathy. Your coronaries could be normal, but your muscle is not as efficient. Ultimately, or a mixture of all this thing leads to heart failure. And diabetes and heart failure kind of have the same common soil hypothesis: inflammation, oxidation, reduced natriuresis, SNS overactivity, RAS expanded interstitial volume, sodium. All this is same for heart failure. That's why all these heart failure trial with SGLT2 included non-diabetic patients too. And this is how it happens, as it's again a recapitulation from Dr. Verma's talk too, because this is a kind of a pathophysiology we have, and that's how it happens. So diabetes and cardiovascular, ultimately you're managing diabetes for cardiovascular outcomes, longevity and quality of life. And still, metabolism in heart is an enigma. But then if you shift the heart failure, ailing hearts, a poor ailing heart's metabolism toward a lesser a good economical fuel like ketone bodies or glucose, then you save the energy of the heart and prolong its life and help it recuperate and help it go into reverse modeling mode. Diabetes and heart failure, I told you, kind of a synonymous thing. And after US FDA's mandate, 3-point MACE, non-fatal stroke and MI and cardiovascular, we are always looking, and all the drug makers are looking, but now heart failure has also been included. And this is where the elephant in the room. Nobody used to talk of heart failure, but ever since SGLT2 trials coming positive, heart failure has been recognized, and all these CVOTs which we are aware have come positive for heart failure for SGLT2 inhibitor. Empagliflozin has set the ball rolling then in 2015. And then when I was there in ESD, and Zingman was representing there in Europe, and this then canagliflozin follow the suit. Hospitalization for heart failure is a kind of a class effect with SGLT2 inhibitors. Enamored with these results, there could be heterogeneity for 3-point MACE, but for heart failure, there's homogeneity. There's the kind of, and for renal protection, kind of homogeneity. And also there is some more heat than the light. We saw that how the benefits accrue. We know that not only they reduce sugar, but they also have a systemic cardiorenal effect. So kidneys were always a missing link in heart failure management. Or a single pill, polypill, and anti-complication drug like SGLT2 inhibitors for heart failure, even in non-diabetic patient, had actually causing afferent arterial constriction, because by blocking the upregulated SGLT2 inhibitor proximal tubules, so much of sodium solute and water loading including the distal, then they're activating the juxtaglomerular activities, causing to getting activated and causing afferent arterial constriction, lesser volume coming into the glomerulus. If you're combining it with RAS inhibition, there's the efferent dilation, afferent constriction, leading to decreased intraglomerular pressure and decreased mechanical induction of transformation growth factors, so lesser glomerular sclerosis. So ultimately, this is a mechanistic proposal how SGLT2 inhibitors are protecting kidneys at the very same time. And then the EMPA-HEART participated in that how they actually in empagliflozin, even in non-diabetic, improves the decreases cardiac mass and improve its in geometric favoring and the lesser activation of neurohormonal. So if you give diuretics in heart failure patient, you activate neurohormonal activity. But this is a smart diuresis here with SGLT2. It is a very natriuresis, aquaurisis, and it doesn't constrict your intravascular size. So this is where they are proposing that the wonder effects are coming how, and more or less it has become a heart failure drug. And they have tested in DAPA-HF and EMPA-reduced, and we have seen DAPA-HF by McMurray and EMPA-reduced by Butler. We have seen that these trials for over and above standard of care of ERNI, RAS inhibitors, beta blockers, and MRAs. Even in non-diabetics, if you use SGLT2 judiciously and given over and above those, a mortality benefit. That's then also in Solois trial with sotagliflozin in this year's virtual ACC last year. And all these trials are out. Emperor preserved. Nothing has come for a heart failure preservation fraction. Emperor preserved with empagliflozin showing a positive signal and tapping the holy grail. So this is where in 2021 you have enriching the molecules, the entities addressing so much of pathophysiological wings of chronic heart failure by antagonizing neurohormonal activation, potentiating a substantial underpinning the endogenous vasoactive peptides through sacubitril, and also you are using SGLT2 which have both metabolic as well as mechanical hemodynamic benefits. So this is where dapagliflozin has shown the pretty standard endpoints: cardiovascular death, heart failure hospitalization, urgent heart failure visit. This composite was down by 26 to 30%. And that has given its place to the guideline makers, compelled them, because one after another heart failure trial with dapagliflozin, even in non-diabetic, are coming positive. So Emperor reduced included even a more sicker patients. So now how to manage diabetes or metabolic syndrome for that sake in Indian patient? Incretin for atherosclerosis, like Dr. Verma said, thiazolidinediones or incretin therapy for anti-atherosclerotic, or SGLT2 for heart failure. And then both are the consequence of irrationally managed prolonged diabetes. As the duration increases with the amount of risk factors, you are having higher chances of. Then you have to use individualized risk assess, see the genotype, phenotype of the patient, talk, and then you have to assess and choose the therapy and assign the targets for that patient. Initially, you have diuretic and hemodynamic effect, and then gradually you have metabolic effect. And then are we ready to bell the cat, in the sense that now there's an era where now, when Eugene Brownwald himself saying, so you have to be, not rather than becoming a thrombocardiologist, you have to become a diabetocardiologist, or all physician or endocrinologist have to assess all organ system in tandem in order to protect a very high vascular risk patients of Indian origin. As South Asian or Indian, as Dr. Abhyuday said, they don't use the word Indian because it could be kind of racial, so they use the word South Asians, and actually they are meaning us, to all guideline makers. So you have these medicines for heart failure. For symptom relief, you have digoxin, diuretics. All these drugs do relieve symptom, but survival benefit comes from ACE inhibitors, RAS inhibitors, beta blockers, heart failure specific beta blockers in heterogeneous class, aldosterone antagonist, ERNIs, sacubitril valsartan, and SGLT2 inhibitors. So they improve survival. And there's another class of drug with approved, is still yet US FDA is approved, but then not available in India, for very advanced, approaching stage recurrent advanced standard of care, all guideline directed optimized therapy, having recurrent hospitalization, very moribund patient, class 3 or ambulatory class 4 patient, very so that is a cyclic GMP and it improves nitric oxide availability and causes a number needed to just 20. And this is actually antifibrotic, anti-modeling, and the thickening reduces hospitalization, all in intramitral flow, LV inflow parameters improves, and it reduces hospitalization. So this is another substance, and very, 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 very fixed dose need to be given, and it's very safe. So this is another through Victoria trial we came. So very high risk patients can be prescribed or might be coming to India very soon for these. So heart failure is a very common complication of multiple cardiovascular disease, or a kind of a panoply of cardiovascular risk that we have in India. Same hypertension, physical inactivity, type 2 diabetes, dysglycemia, or say dyslipidemia, atherogenic dyslipidemia. With we know that we are very peculiar. We are having high TG, low HDL. And then you have not so high LDL, but qualitatively abnormal. This is coming from insulin-resistant IR, which you, like Dr. Prabhudev was telling, and you have a rational explanation for that thing. And that actually bombards and assaults your endothelium every time. And then you develop this syndrome, and many people even becoming a very manifest type 2 diabetes, have a vascular event right away, and then go into that path of heart failure but this all is decided by your genes and your lifestyle and your environmental interaction. But you have to identify the right subset and utilize the available therapy. We have a very enriching 5 pillars of HFrEF therapy now: ACE/ARB, neprilysin inhibitors, beta blockers, MRAs, and now SGLT2 inhibitor. I have not mentioned diabetes here. SGLT2 inhibitor are, of course, anti-diabetic drugs, but they are a kind of a phenomenal anti-complication vascular drugs, have a kind of a very robust heart failure friendly properties that you can have an entire lecture how maybe they decrease your blood pressure, they make you lose your oodles of bad fat you have accumulated. They systolic and diastolic, you improve their central hemodynamics. They preload, afterload is gone down. Your metabolism of heart has eased out. And then there are so many other benefits, metabolic on a long duration. So there are so many vascular benefit coming out of their anti-hyperglycemic action, which is a very unique insulin-independent action. So this is a wheel of heart failure management in 2021. You have all loop diuretics and all for symptom relief. You decongest and you smartly adjust. And then you have iron, isoleucine, hydrogen drug for very few patients who have, it's for African American, but in India also we have the kind of analogy for very select people who have CKDs and high risk feature where you're running short of the drugs and they're stage D. You can just add on ivabradine, beta blocker sub use kar do. Patient is not in atrial fibrillation, still heart rate is high, you can use ivabradine. Metalozone and thiazide like diuretic over and above diuretics when you have sequential nephron blockade, when you need verisuguet in a very end stage patient who is approaching stage D heart failure refractory, awaiting his destination therapy, could be LVADs or cardiac transplant. So this is where these wheels. The standard of the care is beta blockers, MRA, SGLT2 inhibitors, and RAS inhibitors. It could be ACE/ARB or ERNIs, sacubitril valsartan. And ADA 2021 makes us use the right drug, even without metformin, if the compelling need arises because of the heart failure selection. And you may be using, depending upon your CKD, SGLT2, and ASCVD rigs. This is very old. This is how you individualize. आपको देखना है कि आपका वो जो patient आया है उसको heart failure का ज़्यादा है, ASCVD या both. That's how you can choose everything. And the barrier is to medication titration is coming from a mindset. You have to change your mind to understand pathophysiology well. I very again appreciate Dr. Abhi's talk that he has elaborated on pathophysiology in India, which is very important too. You cannot go just like glucocentric. So that's where you have to be very cautious and very, very circumspect and aligned to the pathophysiology prevailing, which wing of ominous octet is prevailing in that individual sitting in front of you. So we have to de-risk CVD risk through individualization. Individualization is the key. And you have to judicially use all these pillars of HFrEF therapy. So thank you. Let's have a discussion. We are already exhausted and exceeded our time. Thanks, Dr. Abhinda. Thanks, HiGlance. Unmute.
Thank you, Dr. Advani, for such informative talk. Now it is time for the question session, which is limited only for 5 to 10 minutes. Allow me to search the question in chat box. Before that, I have one doubt, sir. Can we say that the both disease like diabetes as well as heart disease are increasing in India like pandemic?
It's always a pandemic. This is a pandemic of 10 years duration plus. And this is a pandemic of non-communicable disease. And this is raging and this is increasing and it's going to increase and going to persist in India. It will never go. Pandemic of infectious disease of corona might go, God willing, in few months. But this pandemic is not going to go, and we have to be educating each other like this. We have to learn from each other, share each other's experience, set our thinking pattern right, and keep pace and then stay abreast with the latest development and set those development and practicalize to our patients. I mean, again, it's fifth time I'm telling, because the pathophysiology has to be understood well. We have to understand each individual, and then we have to know what's happening in India. As Dr. Abhyuday said, with good cartoons and good animations and nicely, but you have to learn that thing. If सुबह उठे तो फिर पहले की तरह हम कल जैसे थे. That's where you have to align, and you have to think in that way. So that pandemic is, of course, this is a pandemic of this is an Indian pandemic, which is kind of an endemic in India, but it's a global pandemic, more so in India, right, Dr. Abhyuday?
Yes, very true, very true. Yes, very well. Yes, this is basically we are just seeing, or maybe it's a hype by media. We are not yet means getting a full awareness or a kind of full attention from the media or from the government or from maybe amongst us also. We are not able to make really people aware about this pandemic, which is causing more deaths daily in India compared to what we saw in last couple of years with this COVID-19 infection. In fact, this is a silent killer. We are having lot of patients are dying, lot of patients are having different comorbidities because of hypertension, cardiac disease and diabetes. So I think, as Dr. Advani said, that we should keep on creating awareness about these non-communicable diseases through these type of platforms and amongst social medias also regarding this so-called silent killer pandemics.
Yeah. Sir, one question for you, Dr. Verma. Is the pioglitazone safe or being prescribed on the basis of risk-benefit ratio?
Yeah, very good question, I think. But I would say definitely that yes, pioglitazone, what I feel, this is my personal perspective, that I feel this is a very important drug, because as I showed in my slides, that almost 90% of our Indian diabetic patients are having insulin resistance, and this is one of the best drugs which can reduce the insulin resistance at cellular and receptor levels. And most of our problems, especially related to metabolic syndrome, cardiovascular diseases, etc., they are all related to insulin resistance. And even as Dr. Advani has very well elaborated about heart failure, other metabolic problems, and see, basically these are all from the common soil of the insulin resistance. So I think maybe now if we talk a couple of years later, insulin resistance, heart failure may come up as a part of the insulin resistance itself, as we are talking about atherosclerotic disease. So maybe people would say now that if we start pioglitazone in the earliest phase of even non-diabetic people who are having insulin resistance, we may get less patients of heart failure, because this is all the basic, the metabolic imbalance. Nothing it's like we may have things popping up at a later stage of our life, but the soil is already there. These problems are already popping up in somebody's body. This is just the presentation, the time of presentation. Somebody may have diabetes earlier, somebody may have a heart failure earlier, somebody may have a hypertension earlier, or atherosclerotic cardiovascular disease. So when we talk about the risk benefit ratio, I would definitely say, until unless contraindicated, pioglitazone should be an integral part of diabetes management from the beginning itself.
Very good.
Thank you, sir. Sir, one more question in our chat box, basically from our viewer side. Is the N-nitrosamine, specifically NDMA, was found in pioglitazone? Is this the reason that government authorities banned the drug and said it caused cancer? Is the nitrosamine is the reason behind the ban of pioglitazone in 2013?
No, I don't think. See, pioglitazone is not banned. It was for a couple of weeks. It was just withdrawn from the market, but it was a hoax. There were no studies, and this nitrosamine was not the cause of the withdrawal. It was basically with metformin. There were few samples of metformin abroad, and now also few companies, they have this nitrosamine compound in their metformin drug, which may cause a concern of cancer. But I think good companies, they are not having this compound in their metformin. It was found in few generic brands in US. But pioglitazone, this nitrosamine was not there. There were few case reports in Caucasian population which had some concern in India also. But then this was basically, I won't go in much detail, but it was just provoked by few group of people who I don't want maybe what was their benefit or what was their advantage in doing so. But then the truth came out after a couple of weeks. The problem was withdrawn, and the pioglitazone was never a part of bladder or any kind of cancer.
Similarly happened with rosiglitazone, the Steve Nissen, the paper in 27, which actually prompted US FDA to draw a mandate chart for drug makers. That also proved to be wrong. It was not causing heart attacks. Of course, rosiglitazone then went into a very ignominy and when withdrawn. And then happened on pioglitazone through bladder cancer, erroneously, haphazardly, through some, you said that some people, what they thought of it. It's a wonder drug, as he's saying, and I'm asking through a question that he enumerated a trial called IRIS. Actually, all the patients were having probably not even diabetes, insulin resistance, pre-diabetes. They were all or dysglycemic, and they were phenomenal benefit. And then nobody talks of it. TI. So because I think very few takers for pioglitazone, very few drug makers for it, and had it been a 200 rupees or 110 rupees pill, I think we would have a seminar every other day, right? And there are very few drug makers. And again, but it's not hunky-dory. You have to choose a patient and you have to rightly prescribe. I prescribe even to my heart failure patient. It's a contraindication, a relative contraindication. You have to see how his volume status. Minuscule dose of 7.5 type 2. And if you have a CKD, EHFR of a 17 ml, 18 ml, there are few drugs that can be written, right? And one of them is glitazone that can be written to even ESRD or that. Are very glitazone means thiazolidine means only pioglitazone, no other drug in India or anywhere in the world. Are you approving, Dr. Verma, for even for insulin resistant or dysglycemic patient, not even diabetic now, but they have other risk factors, or somebody who has had a stroke, an HbA1c of 5.8. So would you advocate taking the cues from IRIS trial?
I think it was a very good trial, as you mentioned, that with a lot of benefits, especially regarding to the pleiotropic benefits related to atherosclerotic vascular diseases. But I don't think that it would be means legally safe in prescribing these drugs. We know that we have been using since almost more than 20 years these glitazone, especially pioglitazone, but then none of the guidelines. The problem is that maybe we talk about Indian data, but we don't have our Indian guidelines. We mostly walk around with these Caucasian guidelines, and these guidelines, they are somehow not endorsing the use of pioglitazone, especially for a pre-diabetic individual or an individual with insulin resistance having problems with this insulin resistance. So still, I think metformin, diet control and all, they might have started now.
Even metformin is not approved probably for insulin and pre-diabetes or dysglycemia, not approved. NAFLD, this is another entity which is very common in India, and they say that pioglitazone, even in non-diabetics, can be prescribed. Not again, this is not, and it doesn't reduce fibrosis. You have so many papers coming in for glitazone, but there's no guideline placement. So I just keep wondering, such a wonder drug, but there are no father like this. This guy is a very talented guy, pioglitazone, but no father, no mother. He has found a father in form of Dr. Verma. And I think he's very rightly said, and it emphasized and reinforced the belief of me into as a cardiologist, of glitazone, which is actually for Indian patient, and when many of them, not all of them, many of them, and when judicially used as a cardio safe pleiotropic agent, an anti-hyperglycemic agent, but insulin sensitizer. But then not for that purpose, not for sugar reduction, but for what he said, insulin sensitizing. Most of our ailments in non-communicable disease are coming from resistance, as he said again. So which has to be curtailed. Or exercise koi karega nahi. You have exercise is a big insulin sensitizer, but nobody is going to do exercise. Probably मैं और वर्मा साहब भी नहीं करेंगे अभी 4 महीने तक.
Correct. Very true.
So, ask the last question. One of our viewers want to know.
I think this is the last one.
Yeah, this is the last one. What is the risk of in angiography if CKD patient develop heart disease?
What is that? Come again.
Risk in angiography if CKD patient develop heart disease or heart failure.
Yeah, so it's a high-risk angiography. So heart failure, angiographies don't work. If you have heart failure, you have to first correct heart failure, irrespective of amount of coronary blockages. This is where, see, again, I'm telling you, all these new boys and all, see, I shouldn't be saying something, but we have to be, can't be, likewise, Dr. Verma said, you cannot be glucocentric, you cannot be tubular. Here also, you cannot be luminal. Like a cardiologist has to be holistic cardiologist. You have to see entire body. And if you have heart failure, you cannot go into the numerology of how much percentage block is in mid-LAD, RCA, OM2, hearts. It's not going to function. Heart failure, first you have to collect heart failure, decongest the patient, institute the GTM, all pillars to be there with optimized medical therapy, and manage cardiorenal continuum. Say heart failure, you cannot ignore CKD. You cannot refer to for a kidney. Me and Abhinandan Verma sahab will manage a patient heart failure, his diabetes, his CKD, because I have to see entire in tandem, because there's a crosstalk between organs. So if you have heart failure and I'm sending into angiography, you are going on diabe burden. You are further decreasing first you have to manage heart failure, dry the patient, stabilize the patient, then risk assess. Then you see the cause of heart failure. If it is ischemia or it is ischemia, maybe if you have a mid-LAD lesion or some non-proximal, you don't need an angioplasty or something. But आप पहले ही दिन कर लेंगे तो आप फिर एंजियोप्लास्टी भी कर देंगे, because you will find some stenosis in some Indian patient always, as a doctor is always. So that's where we are mistaken. That's where we are abusing our technology. That's where the clinical cardiology or clinical cardio-diabeto-metabolology, it's all comes in place, and you have to see in toto. And are a single specialist with good knowledge of medicine. I was again Dr. Verma's first slide, endocrinologist and head of the department of medicine. Because medicine is the base. You become endo, cardio, renal, whatever, nephro or gastro or neuro. You originated from medicine. Medicine is always beyond. Diabetes is a medical illness. It's not a endocrine illness or a nephro illness or CKD illness or nephro. I think Dr. Verma, you would agree.
Yes,
that's where the patients are in a mess.
It should be a holistic approach.
Absolutely holistic approach. So अभी जैसे उन्होंने बोला हार्ट फेलियर में, बहुत अच्छा क्वेश्चन है. आते हैं बहुत सारे, उनका क्रिएटिन 1.6 पे चला जाएगा और उनको एक डिम्पल्स, तो वो पहले उसको दिखा लो, एंजियो करा लो, पेशेंट 4-5 जगह घूमता रहता है, और in spite of that he is not on GDMT, in spite of having so that's where in most of the heart failures, angiographies, interventions don't work. I showed the entire exhaustive talk. Did I mention about angiography there? So that's where I think we have to set the thinking right and align with the developments and the pathophysiological processes.
Okay, sir. Thank you. We have come to end the webinar. On behalf of HiGlance, I would like to express my gratitude to all of you for your cooperation, which had enabled us to conduct a highly fruitful webinar. Thanks to all doctors who gave their valuable times. We are thankful for the support you all have given to HiGlance. I would like to express my special gratitude to Professor Dr. Abhyuday Verma from Indore and Dr. Prashant Advani from Raipur. Thank you, sir, for the informative and interesting talk on diabetes and heart failure.
Thank
We
you.
would like to thank our speaker and audience again. Thank you, sir.
Thank you. Thank you. Thank you, Dr. Advani. Good
Yeah,
night.
nice again.
Thank you.
Yeah.